Okay, next up we will be hearing from Enlitic, and presenting for Enlitic today is their CEO, Michael Sistenich. Michael, welcome.
Thanks very much, Paul. I will try to make this as riveting as possible. The space that we operate in is complex, and it's actually within a very complex ecosystem of healthcare IT that underpins the entire health system. What we seek to do at Enlitic is to revolutionize healthcare by leveraging AI tools in order to standardize and extract information out of the healthcare data that is available to us today. So the two main thematics I think that really resonate, that are very broad across industries at the moment, are how are you going to apply AI in a way that generates real value, and in this case, both clinical and economic, and how are you going to deal with your data? And data in healthcare is especially complicated. About a third of the world's digital data is actually healthcare data. And everybody thinks about this as a data lake. The reality today, as many commentators will tell you, is in healthcare we have a data swamp. It is all over the place. The data is siloed. It is deliberately difficult to access. And in cases the health systems, to give you an example, the average US health system, a medium-sized health system, will have 5,000 software systems. The large ones, that can go up to 20,000. How do you link all of this information? How do you make it consumable for your organization and for your patients? And one of the critical aspects of doing that is to basically be able to standardize, normalize, and create a layer in which your data is stable and from which you can actively plan for your organization going forward. If you look at data today within healthcare, there are a lot of companies that are involved in the space. It's extremely valuable, but their primary focus to date has been on the electronic health record. And the reason for that is messy, but it's also relatively easy to handle in the sense that it is language. It's written. It may be structured, it may be unstructured, but it's language. And those files are small and relatively easy to move around. When it comes to imaging, and when we talk about imaging, what I mean is X-rays, CTs, MRIs. These studies, these files are huge. They are difficult to move around and they are complicated because you need to extract information both out of the image itself in terms of the pixel data and the language. And the great complexity in that is sometimes they don't match. And that's one of the issues within the health system today. As a very high overview, what is it that we offer at Enlitic and what are we trying to do? We offer a suite of products, some of which, such as Index and NCOG, that are available today, and others that we are building in our product pipeline that will allow an organization to create that stable layer of data. So to give you a best example of that, if you think about an ocean, at the moment, the different parts of the healthcare IT system are pieces of the ocean. There may be a boat there may be a ship there, maybe a platform there. But the moment you drop something else into that, everything moves around. And you need to find a way to reintegrate that. So the deployment of new software is extremely complex and difficult and expensive. What we do in creating that framework is we stabilize that so that if you change out other parts of your healthcare IT system going forward, that layer of data from which you have built forward-looking use and work cases and workflows remains stable. And for AI to truly work, for healthcare to be able to derive clinical and economic benefit, that is one of the first steps that you have to do. And imaging is a space people have avoided because of how difficult it is to do that in this space. Our suite of products that we've brought today, Index is our standardization tool. And essentially what Index does, and I'll go into this in a bit more detail, is create a standardized naming convention. The words we use in terms of standardization is normalization of that data. In a very simple term, if you go into a hospital system or even an imaging center here and you receive a CT or an MRI, what comes off that modality and goes to the health provider in terms of the radiologist that reads it and the health organization that's going to derive information and treat you. That package is called a DICOM package, and it contains the pictures and it contains written data. Now, the written data that comes off that is different off every machine, off every software version. So even the same GE CT machine, if it has 7 different software versions, it will generate 7 different ways of naming the same thing. On top of that, you have human intervention. The rad tech that's in the room with you is typing stuff in, and he's typing stuff in that makes sense to him. And so all of this information comes off, even within a single organization, in a very, very jumbled and messy way. What Endex does is it normalizes all of that, not just to our own understanding, but also to a framework that can be modified by that organization. So you can think of it almost as a universal translator. Whatever information comes in, we'll give you a dictionary that calls it this. We will also give you the thesaurus that allows you to call it whatever you want, but you can still access it off a stable base. NCOG, in terms of the second product that we have brought to market, is around de-identification. One of the critical parts of sharing healthcare information is the regulations around patient health information. It is highly regulated, and it is very important that that is not shared. And what NCOG allows you to do is now take your data and, in a framework at scale, allow you to de-identify that data. And what that means is removing your name, your date of birth, your address. Sometimes that's not actually written in. It's on a dog tag that someone's wearing. Making sure that that information that can identify a patient has been accurately removed. Not only that, because there's some tools that are available to do that today, but to do that in a way that you can trust, and to do that in a framework that allows you to track what has happened to your data through that process, where it has gone. So if you do ever have a breach, you automatically have an audit trail that can explain why something happened and that you can change that particular process. The next modules that are coming in terms of ENCODE and Insight are other ways to allow an organization to derive value from their data. And ENCODE is around billing and coding, and I can talk to that a little bit, and Insight is around the insights that are available within that healthcare data. To give you a little bit of an idea of what that actually means. In almost every other industry, the value of data accrues to the owner of that data. And those are some of the largest, most valuable companies in the world. You look at your Facebooks, you look at your Amazon, Googles, etc. They are that valuable because they own that data. Healthcare is an anomaly. The people who've generated that data are often your hospitals, your health systems, your GPs. They can't even access that data, let alone access the value that resides in that data. And the value that resides in that data is critically important for 2 reasons. One, there is information in there that allows them to deliver better healthcare to you as the patients. But there's also information in there that allows them to make their systems operate better, to actually reduce the cost of delivering that healthcare or potentially increase revenue. And that is what our framework allows them to do, and it is what they can't do today. This is a snapshot in terms of our commercial opportunity. I know probably difficult to read at the moment. So I'm touching upon most of these points as we go through. So I will skip that, but you can find that in our presentation on the ASX. In terms of very briefly touching upon our leadership team, I myself have a background in healthcare. I'm a biochemist, have held various roles on the financial and operational side over my career. More importantly, the remainder of the team, especially John Marshall, Dan Cosmore, and Steve Rankin, all veterans of the industry, very experienced in creating new markets, bringing new technologies to market, and especially in the case of Steve, he actually has been a founder and CEO of his own business called Client Outlook, which some of you may know was actually purchased by Max 7 over here in Australia and listed on the ASX. Our board is of a similar nature, extremely experienced as directors of organizations, long track records in industry. I'm particularly excited about Lisa Pettigrew, who we recently announced has joined the board. Lisa's background is with a number of large health organizations as well as consulting and technology. She has a deep expertise in commercializing novel new technologies and has recently joined our team. So really has been digging in and helping us in terms of gaining additional traction and accelerating our commercial progress. This is a snapshot of what I've been talking about. And this is where it may be a little bit dry, but this is a highly simplified example of what a workflow within a health organization can look like. Essentially, what we mean by workflow is how do you track a particular process through the different steps in an organization. From patient scheduling your CT or MRI, all the way through acquiring the image, processing and storing that image, identifying what parts of it can you get reimbursement from Medicare or from your own private insurer. Where does that information then go? Is it available for research? Is it available for the physicians to access the critical information they need for better healthcare? These workflows all rely essentially on the same resources, and those are the most critical resources in our healthcare system. Those are the resources that are most constrained, and that's the doctors, the nurses, the rad techs, etc. And the information that we are asking them to handle is growing exponentially. If you think about a CT that you would have had done 20 years ago, it would have had 20 or 50 slices in it. The highest and most high fidelity CTs and MRIs today have 2,500 slices in it. All additional information that they have to consume. If you look at the radiologists themselves, they previously would have been expected to read 50 studies a day. That's up to over 250 studies a day. And you can't scale that. And so within healthcare, and particularly within imaging, it has always been an early adopter of technological solutions. The issue with that is, to those rolling seas and an unstable platform, what you are constantly doing is introducing immature technologies into an immature system that makes it more and more complicated. And to be able to solve for real efficiencies is extremely important. Where a lot of focus on AI has been so far is actually in this particular space around the DICOM viewer. What I mean by that is AI has been focused on, can I generate an algorithm that will look at a picture, for example, an X-ray, and say, this is a fracture, I think this is a cancer. And that resonates. Everybody can understand that very easily. The challenge with that is deploying those solutions into this kind of a healthcare system is very expensive. And how do you extract real economic value and real benefits from that? And that requires an understanding of the data itself. Effectively, you have to create the foundations of a stable data layer before you can actually assess what to do with the pieces of that information. And that's where Enlitic is focused. To give you an idea of how that actually works, in terms of what you see on the left, these are the places from which information in imaging comes. It can be from a hospital, it can be from a referring clinic, teleradiology, etc. Those studies come in and are stored in that little computer screen you see in the middle as a PACS system. It's a picture archiving and communication system. Most of you will probably be familiar with Pro Medicus. It's a raging success listed on the ASX. That is what they do. That is the core piece of IT architecture in imaging. That's where the images are stored, and that's the viewer usually through which the radiologist looks at those images and makes judgments. The issue is, by the time the information goes into that PACS, it goes in the form that it's come off the machine, as I've described. It's a mess. What Endex and Enlitic does is we can either sit in front of that or next to it, and we take that information, create a standardized structure to that information, and redeposit it. The efficiencies you can gain from that are many, many-fold, and that's what we call use cases. The first use case that we brought to market with Endex was something called hanging protocols. And it's particularly dry, but I think everybody will understand it when I explain like this. If any of you have watched House or one of those TV programs about healthcare, you'll always see like someone comes into a room, there's a light box, and they'll stick up a light, a row of 8 different X-rays. That's a hanging protocol. That's not a random series. It is a particular set of images that physician wants put up on the board in a particular way. Your modern version of that, when working with like a PACS like Pro Medicus is a radiologist is sitting in a room, he or she will have 8 computer screens up. And what they want is to double click on a study and essentially all the information to present itself in the right way. So that priors are on the left, laterals in front of you, frontals over here, and over here I'm writing my report. The reality of what happens today is they double click on it and they spend a minute and a half finding files and dragging it to the right place on the screen before they can start to work. It's a waste of time, and they don't enjoy that. What we do with Index, you can imagine, and the reason why the information can't go to the right place is you can't create a structured and rules-based system to handle information that is messy and isn't called the same thing every time. Once you have done that, and we chose this use case because it was so simple to demonstrate. Once you have standardized data, you can now pick exactly what piece of information you want to go where on the screen, and you can create a set of rules that will do that when you double click on that patient file. When that happens, what we're effectively selling back to an organization is time, it's capacity. It's that time saving that the radiologist has. They have a better experience in terms of their work environment, and that time is critically important to the volumes and the amount of processing they can go through. Other derivatives of that in terms of workflows are in other areas that are clinically adjacent. And what we must remember, like to have a strong economic proposition to the end clients to undertake the difficulties of installing and implementing these kind of softwares. The business, the organization has to derive a benefit. So for example, a number of our clients when we first arrived said, look, can you just tell us simply within this CT, is there or is there not contrast present? Contrast is essentially a meter you give to a patient so that when they undergo that process, it will show something different in the image. When you do that, you receive additional reimbursement because you've given something, you've done an additional procedure. The challenge is that information often gets missed along the way, depending on how good your organization is, 5 to 30% of the time. So if you have a simple output that says there is contrast in here, you will not miss that anymore. And that can be worth $300 to $1,000 of additional reimbursement every single time. That's one example. Another example is in quality control. So these are different aspects of what you can get from standardized data. One client, when we ran our proof of concepts in the US, we looked at their data and we came back and said, do you realize that you have a massive laterality conflict in your data? And what that means is the report that comes in, for example, will say, do a left leg CT. The image is very clearly a right leg CT. And the RAD in his report has written it up as a left leg CT. And so you can imagine, like sometimes that's going to sail through and it's not going to be an issue. But at times that can be a really significant issue for the patient and for the organization. They said that can't be the case. It turned out they had 13% of their cases had a laterality conflict of some kind. That allows an organization to improve their processes, reduce their liability, make the outcomes that they're delivering to patients better. So those are some examples of what you can achieve with Index. This is a part of an illustration of how does that fit within an ecosystem. Once you have standardized data, if you can now de-identify that data, what you have effectively created is a proper data lake. A data lake with standardized, de-identified data that you can move around, that you can search, that you can look for cohorts, and you can actually identify and derive further insights from your data. And most importantly, you can potentially sell. Like it's one of the big dirty secrets within healthcare is that our healthcare data is being transacted all over the place. Large pharma companies, medical device businesses, contract research organizations want access to that data. The insights that they have in that data are extremely valuable. The way the system is structured today is that the raw data itself is often not particularly valuable because you have to do a lot of work with it. So a pharma company, we're currently working together with, as they say, like they'll pay $5 to $25 for a study. They will expend 80% of the total cost of deriving information from that study on standardizing and making that information consumable. So that is, again, part of how we impact different parts of this ecosystem. I'll skip through that. In terms of the product offering and going to the economics and the business model, Index and ENCOG, I hope you can see that, they're the two on the left, are the ones that we currently have live in the market. Our entire business model is a software subscription model. So very similar, again, to the PACS vendors like Pro Medicus, but just on a slightly different scale. Organizations will come up to us and sign up for 3 to 5 years on a contract on an annual subscription in order to use that software. It is important to understand that what they sign up for is usually for a very specific set of features, i.e. if you're signing up for hanging protocols, that's one price. If you want to use the feature that gives you billing advantages in detecting contrast media, that's an additional price. If you want to use it for all of these additional workflows that we have, that stacks over time, and that goes to part of our land and expand strategy. ENCOG stands as a separate tool, and in terms of ENCODE and ENSIGHT, these are the tools these are the features that are coming down the line. ENCODE I've actually touched upon. ENCODE is a more comprehensive suite of billing and coding features. The feature that I explained about contrast media, we already have a second feature that was requested by a client, which is, can you just list what body parts are present in a scan? And the reason why they want to do that is in some geographies, like in the NHS in the UK and in Japan, you are reimbursed by complete body sections. So whatever organ is actually scanned, you get reimbursement for that. So you can imagine a lot of the time what happens is someone goes in for a chest CT. But what they actually do in the NHS, they scan chest, abdomen, pelvis. The radiologist knows the request was for a chest CT. He will focus on writing up a report about the chest. You just missed 2/3 of the reimbursement you're available for. So what ENCODE is a more comprehensive suite of those kind of features. What you have in terms of ENSIGHT is ultimately a framework that allows the client themselves, the health systems, to access that data and derive their own value. Give you an understanding of what that means. When we standardize data with Index, but when we standardize that data, we can deposit that information into a database. We can deposit the information as, what did your guys call it? What have we called it? What are the different ways of calling this when you're working in different environments? We have a richness of information in that database that is not usually available. It goes down to, what machine was this done on? What software version of that CT machine was this done on? How long did that take? What was the dose of radiation the patient took? Which rad tech did it? Did they follow protocol? And with that information, we provide that as a framework to our client, and they can help, and they can figure out what else is valuable to them to derive value from that. And that starts to change significantly the value proposition that we provide to our end clients. If you look at our go-to-market strategy, what we have is essentially a data standardization tool that exists as a layer. The power of that is that once an organization starts to standardize their data to this framework, they need to continue to do that. Otherwise, their data going forward is no longer the same. The second aspect of that is the network effect is extremely powerful of having a framework that can interpret information from different sites in the same way. And so our strategy is to get it out there as quickly as possible and as broadly as possible. If you look purely in the US, there are over 6,000 health systems. On top of that, there are radiology reading groups, teleradiology groups, etc. It is not possible to do that purely with a direct sales force. So our question is, where else in the ecosystem do we have value? And how can we use those as force multipliers to get our software out there? Because you can imagine, once we can sell you standardized data, it is much easier to sell you features that allow you to derive value from that standardized data. Our OEM partnerships have been announced. For example, GE, largest market shareholder in the world, has already been announced. We're working actively together with them in terms of Infinite and Multi. There are other channel partners. Okay. Does that mean I have 3 minutes or it's done? Okay. In terms of distribution partners such as Marubeni in non-core geographies to ourselves, one of the 5 big trading houses, they're actively distributing in the US. AI platform vendors, for those of you over here who know Analyses, that's exactly what they're trying to do. And you can imagine from what I've explained, it is easier for them to sell more algorithms if the data is standardized, because then you can plug it in exactly the same way every time. Data migration, companies that move healthcare information and imaging information around. If you are going to undergo a multi-year process to move your data around, having standardized data at the end of that process is a marginal increase in lift, but a massive increase in value. So those are other partners that we expect to come down the line, and then obviously those that sell healthcare information. I will skip through the growth opportunities because I think this is a slide, everybody. Healthcare, everybody knows healthcare IT, it is a long sales cycle. We started commercializing at the beginning of 2022 with our first client, TMC, which is one of the largest radiology reading groups in Europe. We have built this pipeline over that period of time. These are not leads. When we talk about a pipeline, we're looking at right at the bottom what we think of as opportunities. Qualified opportunities, those with whom we've had engagement at senior levels, who've demonstrated a willingness to buy, who understand the technology and has often run a proof of concept. We split those into 2 categories, pending progression and open opportunities. Open opportunities are those that are actively progressing today. Pending progression are those that are blocked intermittently for some reason. Usually that is because they don't have one of 2 things, IT bandwidth to deploy or budget within this cycle. That is important because you need to have that in place because that is what you're converting in order to generate forward-looking revenue. Give you an example through 2023. We started the year with our 1 client, TMC. We ended the year with 11 clients as we start to accelerate to convert this pipeline. These are some of the clients that we have, and you can see that there's a real breadth here in terms of the clients that we have. Vital is our first NHS provider over in the UK. It's an NHS overflow provider, so it's not a direct NHS relationship yet, but that is one in the UK. Centara is a mid-sized US health system. TMC, our very first client, one of the largest radiology reading groups in Europe. They are a subsidiary of Unilabs, which is a pan-European group. You may have seen at the beginning of this week, we made an announcement of our expansion of our relationships. That is a demonstration of our land and expand strategy. TMC, our first client, had a 3-year contract with us originally, and that started at the beginning of 2022. The benefits that they have derived from the utilization of our tech enabled them to represent that up into their mother organization, Unilabs, and we consummated a 5-year relationship with Unilabs, which was an extension and expansion of our tech to roll out more broadly across their 180 centers in Europe. And that was signed on Monday. That was particularly exciting for us because there is no better demonstration of someone paying you and be willing to pay you more because they're liking what they're seeing. Wake Radiology, SEER and Summit are additional US health systems. Our distribution channels there along the bottom, particularly important is actually Blackford. Blackford is like an Analyse or an AI doc. They are an AI platform vendor, and there is validation here that one of these has already come on board in their recognition that having us on board will allow them to execute their strategy better. More importantly, they are owned by Bayer. So that's one of the large pharma companies who are actively looking at how to handle data better. And they are also the white label provider of AI solutions to Philips, the number 2 market shareholder in the world. Between GE and Philips, you have about 45% market share in terms of the OEM vendors. So this is an example of how we are executing against our strategy in getting our technology out there as quickly as possible. I think I've now overrun. I will pause. This is our summary slide. There's nothing else to take away. What we do is we apply AI tools to derive real clinical and economic benefit for the healthcare system. We focus on handling data and in activating and extracting the value that exists in healthcare data today. Thanks very much.
Many thanks, Michael. Actually, the first question is actually coming from myself, just trying to understand AI and how you use that technology. I want to give an example of something that happened to my wife last year. She had a hip replacement, and I was quite surprised of how long it takes to get an MRI done. Having the MRI done, waiting 4 or 5 days before the radiologist is giving the report that goes to the doctor and the specialist, and then when we receive the report, trying to understand it, because I'm no medical expert, nor was my wife, and words in there that we just didn't understand. So correct me if I'm wrong. The technology you have can expedite this process, and not only expedite it, actually produce the results in a language that people can actually understand. Am I on the right track there?
You are, and you talked about 5 different workflows in that one commentary. To give you an example, one of the things we can do, and it was asked for by a client, was saying, can you tell us with accuracy how long it takes to do a particular study? We said, yes, but don't you know that? They said, well, we don't really work that way. For a particular MRI, we just schedule 60 minutes. So if you can tell us, and we have that data, accurately that is on average 40 minutes. I've just increased the capacity on my very expensive multi-million-dollar machine by 1/3. That goes to your capacity in waiting for patients to be able to even get a study done. Then you went to waiting 4 or 5 days. Those are like service level agreements, turnaround times, critically important. How do you actually look at information and go, is this emergent? In your wife's case, I don't know what the scan was, but sometimes it's something that needs to be handled right now. It might be a stroke. Can you identify which of those cases should be immediately looked at? Which of those cases can actually take a little bit longer because they're not as urgent? So that's another use case from that particular data. All of that, in terms of turning it around and in terms of structuring that data, allows an organization to apply other AI tools like those that look for a cancer or look for a fracture or look for a bleed in a more efficient way. So that then goes to the consumability of that data. So in one example, you touched on multiple points where our technology is applicable. And once you install it once, it is about deriving these different features and use cases. That's what we help our clients do.
And you also mentioned that let's say you're doing an MRI on the hip, and that's what the radiologist is focusing on. But again, in the case of my wife, that also she had cysts on her ovary. And there wasn't detail on that because the radiologist was concentrated on the hip. And it sounds like you have the technology to encompass all the data on the MRI.
What our technology does is it doesn't necessarily look for that additional finding, that additional cyst. What allows a radiologist to do is actually understand the information that's in front of him in a more efficient way. The other AI diagnostic algorithms do exactly what you were talking to about additional findings. But in terms of how our AI works, we have natural language processing that extracts information out of the metadata and the reports and the orders. We have computer vision that extracts the information out of the pixels in the images themselves. And then importantly, we have additional layers of machine learning algorithms that sit over the top that says, in the case when there is conflicting information here, what is the right piece of information that actually needs to be conveyed? If it says left in the order, right in the image, left in the report, what's the right answer? Well, the right answer in that particular case is going to be what's in the picture. And so those are the types of things that our solutions do.
Thanks, Michael. Please, this gentleman here.
Do you have any competitors who are developing similar solutions anywhere in the world?
So it's interesting. In terms of what we do, there isn't a direct competitor. And what I mean by that is, if you look at large systems at the moment, in terms of how do they standardize their imaging data, and I'm not kidding, they will have 20 people in a cellar manually standardizing this data. And so the alternative to purchasing Enlitic is not that there is another software version available or another solution available currently. We are often lumped into the AI and imaging space, but most of those companies are focused on diagnostic and triage algorithms. Within healthcare data standardization, there are a lot of valuable companies. You look at a Datavant, does $700 million in revenue. You look at a Komodo Health. Those are the ones that are focused on linking the pieces of information in the healthcare system, primarily focused on the electronic healthcare record.
what's your current cash runway? And I believe there's a company called Beam Holdings that's in the same, or some that has a similar name, that has a similar place in your technological space. How would you differentiate your strategy compared to?
So there are a lot of companies that will say they do some aspect of data standardization and interoperability. It's extremely complicated, I think, as we've touched upon, and it really depends on exactly what do they mean by that. There are a number of companies out there who say that they will standardize imaging data. The question is, what are you standardizing and how are you doing it? Is this automated? I'll give you a very simple example. Every single OEM vendor has something that's called something along the lines of smart display protocols. And that's for hanging protocols, because this is a problem everybody knows exists. Every OEM vendor has a solution to that. The solution to that is they'll create a conversion table for your data. At that moment in time when you test it, it works beautifully. But the problem is that that data changes and often goes stale within a large health system within 2 weeks. And what that creates is a manual labor to maintain that table over time. And either it's done by the OEM or it's done by the healthcare system, neither of whom want to do it. And it's still, because it is manually done, introduces human error. So it's very, very specific. Within what we do and utilizing technology to standardize imaging data, there are a number of companies that do something that is a derivative, but in terms of direct, certainly in our interactions with our clients, if you look at the relationships that we've built, there's nobody else that's doing that in the same way, where the OEMs or the end users have bought into that kind of solution.
Okay. And as far as the approximate current cash runway in terms of time or capital, what's that?
Certainly, I think you'll see in our annual report that's coming out, we have cash runway essentially for the period of time that we demonstrated within our prospectus, and that's currently, we're listed, and I think that's what you can see. Will we require capital at some point further in the future? Yes.
Okay. So you can't quantify approximately the time span for the next capital raise?
I can't, I know it. I can't give additional guidance that hasn't been publicly disclosed, right? You can understand that. So it's still exactly, you can refer back to the prospectus as of today. Thank you.
There's a question here. You obviously only listed back in December, and the question here was, why did you choose to list on the ASX versus the other exchanges?
Yeah, very clearly. Enlitic is a US business, but it has always had an extremely strong connection to Australia. The original founder of the business was a chap by the name of Jeremy Howard. If you actually look him up, he was one of the titans of machine learning, Australian by background, and had moved over to the US. In the original founding of the company of Enlitic, both the data and a large part of the investment came from Australian investors. And that relationship with Australia was really maintained over time. So if you look at our cap table, it's heavily Australian, with a number of US VCs that backed it. When we looked at the development of where the organization is, where is the most suitable place for this company to be listed for an investor base that would understand that, and also an investor base that would understand what the value of this is going to be as we execute it. There are some great comps here in Australia, whether it is 4DX that's earlier, whether it's Max 7, or whether, of course, the shining light that is Pro Medicus. So there's an investor base that understands the proposition.
And you did touch on this in the presentation. Can you remind everybody what is your commercialisation plan?
In terms of the commercialisation plan, I think gave you a little bit of a flavour on two. One is the conversion of this pipeline. That is the most critical aspect. These are relationships that exist. These are companies that have indicated a need for the solution, and it's about converting that. That is what you need to see. That announcement of what has happened just recently with Unilabs, what other ones we're bringing down the line, which OEMs we're going to be bringing on board. Converting that pipeline is the number one priority. The second priority that we have within the organization is to accelerate the delivery of these additional features and use cases, because essentially that's the burden of proof. The more we're able to deliver, the more likely that someone's going to be willing to pay us for it.
Michael, many thanks for your time.
Brilliant. Thanks very much. Thank you all.